So next presentation will be by Dr. Shashank Saini from Varanasi. He is a uro-oncologist. He'll be speaking on bladder-sparing therapy for BCG-Unresponsive non-muscle invasive bladder cancer, International Bladder Cancer Group recommendations.
Good morning to all present, and thank you scientific committee for this opportunity. So the abstract given to me is this bladder-sparing therapy for BCG-Unresponsive NMIBC, and this is not a trial. This is basically recommendations from experts world over from the International Bladder Cancer Group. So the background for this paper is recent surge in the developmental agents for NMIBC, non-responsive, and there are no RCTs comparing these agents or dearth of literature. Most of them are single agent trials or studies, and practical recommendation for these agents and sequencing of these agents is lacking. So that was the background. The objective was to formulate recommendation to help us in optimal selection of patients and therapies for BST in BCG-Unresponsive NMIBC. So the methodology used here is a modified Delphi method in which they gathered experts from uro-oncologists world over. There was surgical oncologists, uro-oncologists, radiation oncologists, genitourinary pathologists, and patient advocates also, who upon search of literature and based on their clinical experience when appropriate, they set out certain recommendation, and they were revised with several online meetings, and finally they came to a conclusion on August 2023 where recommendations was laid down, and the laid down recommendation had at least 75% agreement among the members. So before going to the recommendation, I'll just summarize what is a case. Defining a case is important. What is a case of BCG-Unresponsive NMIBC? As Amitabh sir already told in his presentation, I'll not be repeating that. What is a BCG-Unresponsive as given in this table? Optimal staging is very important before we define any case as BCG-Unresponsive, because it has been seen that sometime due to lack of staging, cross-sectional imaging, or even a decent TURBT, we could be dealing with a muscle-invasive disease, and patient is unnecessarily receiving many toxic therapies. So that is important. Other thing is standardized pathology report. This I think is important when we are dealing with high volume centers. There are slides being seen by a person who is trained in genitourinary or bladder cancer. Wrong reports can lead to harm to the patient. So what are the treatment options? In this paper, they have basically categorized the treatment option according to the chemotherapy based options, immune checkpoint inhibitor, gene-based therapies, intravesical immunotherapy, targeted agent, and other miscellaneous therapies. So coming to the chemotherapy-based option, first we have the single-agent chemotherapy, which most of us must have used in our practice, in our uro-oncology practice, mitomycin, BCG, and gemcitabine. So for mitomycin, it was clearly found that the optimized mitomycin, the hyperthermic mitomycin, has recurrence-free survival of 58% at 12 months and 36% at 24 months. The patient who had papillary tumor did better, however. They had 71% and 56% recurrence-free survival, and it was better. And it was seen that when giving hyperthermic MMC, the recurrence-free survival, even at long terms, 5 years, was significantly better, 41% as compared to 25% for the CIS group. Then gemcitabine, single agent gemcitabine, it also showed that the papillary variant of the tumor, where the CIS component was not there, did better when single agent gemcitabine was used. Valrubicin, as sir already told, that it was initially developed as a substitute to, or you can say after BCG, where to go, but it actually was not developed under the BCG unresponsive definition. So single agent chemotherapy, the cancer group concluded, may be considered, but seeing the results of the CIS group, they said it should not be used in the CIS group, may be used in the papillary tumor group. There are other studies going on. The Sunrise trial for TAR-200, settlemap is going on for BCG unresponsive tumors. So after single agent, the gemdosi, the go-to drug for I think most of the uro-oncologists after a BCG failure, though not officially recommended, used widely off-label. Recommended based on the long-term survival data also, that 5-year data is not available with 92% cancer-specific survival after 5 years. So gemdosi, according to the group, is the intravesical option of choice when using combination therapy. We have several immune checkpoint inhibitor in this paper. They have studied, by the Pembro is the most studied one, and they have given a rider along with that it should be used when all other options have been exhausted. The reason being that it is associated with grade 3 and grade 4 treatment adverse effect, which are in the tunes of 20 to 30%. Rest, atolizumab and atozumab with BCG, the trials are going on and further data is awaited. Now we come to gene-based therapy. Everyone would have heard this fancy name, nadofaragene. So it is showing promises, and was after a trial in 21, it gained approval in 22 and is recommended now for treatment in BCG-unresponsive group of bladder cancer. And everybody has been knowing it's basically you're making the bladder a bioreactor to produce more interferon 2 alpha to fight the bladder cancer. That's the basis of this. The other gene-based therapy, CG70, which is being studied, looks like some missile name. Bond-03 trial, Core-01 trial are going on, but recommendations are not there according to the bladder cancer group. Then we have the intravesical immunotherapy in this nadofaragene, NAIA or N803. Basically what is doing it, enhancing the bladder immunity by serving as an interleukin-15 superagonist. And it gained approval in April 24. To be used with the BCG. So that is the part here, because in West they are already suffering from BCG shortage. So they have some reservation about it. How do we go about this using this agent? However, the results are good as shown in the QUILT-3 study, the QUILT trial. This is the latest which they present in the ASCO and AUA. Should be used with 50 milligram intravesical BCG. Cystectomy free rates as 36 months are 84% in the CIS group, and cystectomy free rate at 82% in the papillary tumor group. But treatment related reverse effect are less, only 3%. So coming to targeted treatment, there are 4 agents in this group. Due to the want of time, I will not be going into their response rate, but none of them have been approved for formal use according to the cancer group. Dafitinib and vindoitin, they are basically used in advanced and metastatic urothelial cancer. Further data is available, awaited actually, to see their use. Maybe in coming years they will gain some recommendation. Other treatment option, TURBT and fulguration for unresponsive tumor not recommended. Patient should enroll in a trial. Photodynamic therapy research is going out, but no formal recommendation. Radiation based treatment should be used in patients who are ineligible for radical cystectomy or have no access to bladder sparing options and cannot participate in a trial. So coming to the final general recommendation, at the time of BCG unresponsive diagnosis, a bladder sparing therapy must be offered to selected patients. Now all of us know these selected patients who are fit, have no lymphovascular invasion, no variant histology. Therapeutic failure should be considered when there is a progression to T2, N1 or M1 in 12 months. Progression to muscle disease should prompt a multidisciplining team meeting, because it has been shown that even after progression, neoadjuvant therapy before radical cystectomy after BST failure has proven to be helpful rather than going for an upfront radical cystectomy. At each tumor recurrence, restaging with TURP, bimanual examination and cross-sectional imaging should be done. Non-muscle invasive therapeutic failure for BST and refuse who are ineligible for RC. Additional trials can be done, but with a caveat that patient should be counseled that with every failure of one BST therapy, you have a high risk of progression to metastatic disease, which is in tune of 20% at 2 years. So the general recommendation is that it's not a single line for every patient. It depends on patient preferences, where is coming from, what are the tumor characteristics, a variant histology, efficacy and toxicity profile, which is patient agrees to that he is ready for that. And this is the key picture from this paper. For the CIS and papillary group, there is gemdosi, no single agent chemotherapy in the CIS group, nadofaragene, NAI plus BCG or pembrolizumab as the last resort. For Ta-T1 disease, we can give single agent hyperthermic mitomycin, gemdosi with all other agents also. So this is in concurrence with other guidelines world over, EO 23 and AUA also. They have also similar lines. So concluding, patient with BCG unresponsive NMIBC should be treated with initial BST. Each failure increases the rate of progression. As I already told, if multiple lines, it goes up to failure. Metastatic rate goes up to 20% in 2 years. And recent meta-analysis have shown, raised doubt about the durability of these drugs, because the responses are, like Amitabh sir told, is 15% in 1 year to be best. So conclusion, it should be based on patient characteristics, and further evidence is awaited from the RCTs going on. Thank you.